Good day, everyone. I'm Pooja Joshi, your host for today's episode. In this session, we focus on a condition that is common yet often misunderstood: irritable bowel syndrome, or IBS. To help us navigate this important topic, we are joined by Dr. Apurva Shah, gastroenterologist at Apollo Hospital, Gandhinagar, a respected expert in functional gastrointestinal disorders. Today, Doctor will walk us through early symptom recognition, simplified diagnostic approaches, and effective, evidence-based management strategies for IBS in routine clinical practice. Doctor, thank you for being with us. Let's begin our discussion.
I'm Dr. Apurva Shah. I'm a senior gastroenterologist and hepatologist practicing at Apollo Hospital, Ahmedabad since last 10 years.
So, doctor, question for you is, in your experience, how does a typical IBS patient present in an OPD?
Yes. So IBS means irritable bowel syndrome. So typical irritable bowel syndrome generally presents with chronic relapsing abdominal pain, which is associated with altered in the bowel habits. It may be in the form of either constipation or it may be diarrhea. Generally, the pain is relieved after passing the stool. So this is a typical history, and generally the symptoms are more than 6 months.
How does modern lifestyle, food habits, stress, and sleep contribute to IBS?
Okay, so first we'll take, there are three components of it. First is food habits, second is stress, and third is sleep. So if I tell food habits, two main important point is those who are consuming high FODMAP diet, that is fermentable oligosaccharide disaccharides. These are the foods which increases the bloating and gas formation in the stomach. So this causes worsening of symptoms. So they should avoid high FODMAP diet. Second thing is processed foods, which are not good in IBS patients. So these are two bad food habits which worsens the symptoms. Second point is stress. So any level of stress that will release certain hormones in our body, and that hormones will lead to visceral hypersensitivity. That means our gut feels more pain than usual pain. So the stress against it worsens the symptoms of IBS. And third important point is sleep. So in our body there is circadian rhythm which is generally maintained. So regular hour sleep of 6 to 8 hours, which is very important. If the sleep is disturbed, then again there is a gut-brain axis which get disturbed, and again it will contribute to the worsening of the IBS symptoms.
What are some common mistakes in diagnosing IBS at the primary care level?
Typically, the common mistakes occurs for diagnosis. Generally, the irritable bowel syndrome diagnosis is clinical. So if you take proper history of the patient, generally the diagnosis is confirmed. In majority of the times, we require very few blood investigations for confirmation. So the mistakes occurs if you are giving too much investigations when first patient presents with symptoms of IBS, then it unnecessarily adds to the cost of the patient, and it will again increase the stress because majority of the investigations are normal. So that is one mistake if you are doing too much investigations for diagnosing IBS. Second mistake is sometimes you have organic disease and you are labeled as a irritable bowel syndrome. So in that case also does not delay the diagnosis. If you have certain red flag signs such as weight loss, blood in the stool, severe abdominal pain, which is not compatible, so in that case you should diagnose it early rather than late, so that there should not be mistaken for the other diseases like IBD, inflammatory bowel diseases. So both things are very important, that mistakes occurs at the primary care level and should be taken care of.
How do you tailor treatment between IBS-D, IBS-C, and mixed IBS?
Yes, so when treatment of irritable bowel syndrome is concerned, mainly at present we are focusing on two things. One is symptomatic relief and improving the quality of life. Because of this is a chronic and relapsing disease, a patient has to continue the treatment for long duration. So once they stop the treatment, there is a relapse of symptoms. So tailoring the treatment, we have to see which type of irritable bowel syndrome we are dealing with. So if patient presents with diarrhea predominant IBS, then generally the first line treatment from our side will be anti-motility drugs like loperamide and rifaximin, which is antibiotic oral. So these are the two main things where we give in IBS-D patients. If it is constipation predominant IBS, then generally we give symptomatic relief in the form of laxatives. Most commonly, first line medications we are using is polyethylene glycol. And if it is still not controlled, there are very good newer molecules. Linaclotide is now available. So these are the kind of different medications which we are using for IBS-C patients. And if it is a mixed IBS, so we have to take care of abdominal pain also. So that is very important in IBS patients. So apart from that, diarrhea and constipation treatment, we have to give analgesics which are not having systemic side effects. So gut selective analgesics we generally prefer, like it may be mebeverine or pinavarium bromide. These are some of the gut friendly analgesics which we are using regularly. And apart from that, majority of the IBS patients, they also have some psychological issues, maybe anxiety or depression. So we have to take care of that part also. So we have to add some nortriptyline or amitriptyline medications, which are better for their anxiety and depression level, or SSRIs in the form of escitalopram or sertraline. So these are some of the medications which we are using based on patients' phenotype, whether they are constipation predominant, whether they are diarrhea predominant, or they are mixed.
What's the most memorable IBS case you've handled, and what did it teach you?
I remember the most memorable IBS case, that is patient who is having multiple consultation with many of the gastroenterologists in my city, and he brought almost more than 10 files, different files of gastroenterologists. This is a typical in case of irritable bowel syndrome. They just roam from one doctor to another doctor if they don't get relief. But as I have told you, the history taking is time consuming, but it is very important part of IBS. So one case which I am discussing right now is a female of approximately 35 years who has consulted almost more than 10 gastroenterologists. And when she came to me, her primary symptoms was diarrhea predominant IBS from the history. But the problem was not only the IBS. There are associated psychological issues which were not managed properly. She has been given some medications, but there was no improvement. So when she came with me, apart from IBS treatment, what I have done is counseled her for her psychological problem, and I have also told to meet the psychiatrist. So there was a counseling by the psychiatrist. Psychiatrist has started the treatment, and within 3 to 6 months, this patient was so happy that doctor, I am very happy now. My symptoms are very much well controlled. So here the lesson was, it was not the symptoms of IBS which was causing problem. Here the psychological issue which are triggering the symptoms of IBS. So it is very important that if patient is having associated psychological problem, just take a help of psychiatric friends. Counseling also helps by the psychiatrist. Even though majority of gastroenterologists are prescribing medications, but certain counseling is important when they having a major depression or anxiety disorders. So this is the case where we require multidisciplinary action rather than taking medications and telling the patients you will get better, you will get better. That's not an issue. So better to take help of other friends when it is required.
What advice do you give to patients for long-term gut health and relapse prevention?
So for that, I will require basically a non-pharmacological lifestyle changes, which are very important rather than pharmacological. So very important is keep your meal time regular, take proper consistent sleep and maintain the schedules. Second thing is eat slowly, avoiding gulping the airs, and avoid the food triggers. So I generally advise my IBS patient a personalized diet, because if you generalizely tell them to take low FODMAP diets or you avoid this much food, that is not good. So generally I tell them to make a diary of the food which makes their symptoms worsen. So that food I want to avoid now. The patient will himself or herself decide what food is triggering symptoms in them, and I want those foods to be avoided rather than generalized low FODMAP diet. Very other important thing is stress management. I generally tell them to do some brisk walking, yoga, some physical activity in the form of sports that will help to relieve the stress and regular exercise. So these are some of the aspects, non-pharmacological lifestyle changes, which helps patient for long-term gut health and prevention of the IBS.
What's your message to young doctors who hesitate to label a case as IBS?
Very important. So for young doctors who are hesitating in labeling the diagnosis of IBS, my message is just be confident, because irritable bowel syndrome is a clinical diagnosis. So when you take proper history, do the physical examination and necessary investigations like complete blood count, stool evaluation, TTG antibody if patient is having diarrhea, thyroid profile, diabetes. So primarily 3 or 4 investigations which are necessary. Generally, majority of them patients when presents, they usually have this kind of primary investigation which are already available to the doctors. So if you take proper history and primary investigations are available, just don't hesitate to label this patient as IBS. You have to counsel this patient, yet yes, you are suffering from the irritable bowel syndrome. You have to take medications for longer period of time because of its relapsing and remitting disease. But taking medications, stress management, psychological aspects, all these aspects, if you counsel them properly, generally patients gets better. So I tell them to follow Rome 3 or Rome 4 criteria, and if red flag signs are absent, like weight loss, anemia, blood in stool, palpable lump, these are some of the red flag signs. So if they are not present and history is of longer duration, certainly you can make the diagnosis of IBS. You does not require much more investigations, and just label and treat the patient as IBS rather than referring them to one after another doctors.
The most common mistake you see in IBS management?
Yes, so when IBS treatment is concerned, as I have previously told you, apart from symptomatic treatment, whether you are dealing with pain, whether you are dealing with diarrhea, or whether you are dealing with constipation. So apart from these symptoms, you have to treat the patient as a whole, not only the symptoms. So important thing is you have to take care of pain thing. Sometimes if you don't ignore the pain, if you give the medications for diarrhea and constipation, and if you ignore the pain, patients will again come to you or will not be following you after a second time. So pain management is very important. Second thing is you have to also see the psychological aspect and gut-brain connection also. So if those patients who is having psychological issues like anxiety and depression, that are also should be taken care of with good lifestyle and stress management.
One food you tell IBS patients to avoid?
So it is not a single food which I can tell the IBS patients to avoid, because as I have told you, all the patients should not have generalized approach. So generally in IBS patients, I tell them to avoid high FODMAP sweeteners and sugar alcohol, which contains sorbitol and xylitol. But majority of them, I tell them to make a diary, and that food which is causing worsening of the symptoms, that is the best food to be avoided in IBS patients rather than generalizing it for low FODMAP diet.
One word that describes a typical IBS patient journey?
Okay, so I can tell you, after a long frustrating journey of multiple tests, sometimes misdiagnosis, and feeling unheard, proper confident IBS diagnosis, which is most important step toward recovery and long-term management. So follow the Rome 3 or Rome 4 criteria with confidence, without going multiple areas of the investigations, and also treat the patient as a whole, all the aspects of IBS, not only the symptoms. Thank you.
Thank you, Doctor, for sharing such valuable insights on IBS. Your clarity and practical guidance will certainly help both physicians and patients approach this condition with more confidence. To our listeners, thank you for joining us. Stay tuned for more expert-led conversations. Until then, take care and prioritize your gut health.